Hi everyone. So my name is Amy, and for my Keystone Symposium project, I did a project on HIV in Vietnam and how patients living with HIV can achieve viral resuppression. So my advisor for this project was Dr. Eileen O'Keefe. And so before we begin, I wanted to start with a couple of definitions so that way we're all on the same page in terms of just concepts and understanding. So HIV, human immunodeficiency virus, can destroy the immune system and lead to acquired immunodeficiency syndrome, commonly known as AIDS. It's commonly spread through bodily fluids, so things like anal and vaginal sex are common modes of transmission. Viral load is the number of copies of virus per milliliter in your blood. So you get your blood drawn, they run a test, and that just tells you the number of copies of virus you have. Enhanced adherence counseling is counseling to help patients determine why they're not responding to their antiretroviral treatment, ART for short. It's their drugs, and so it's typically done over 3 sessions, 1 session per month, and it's supposed to help patients identify what's happening in this process that makes them no longer respond to their drugs. And so that cascade of care, it's a series of 5 hexagons, and so it's essentially the steps that you take to go through when you become HIV positive. So the first step, obviously, is that you are diagnosed with HIV. The second step is that you are then linked to care, so you go to a doctor. That's your second step. And then your third step is that you are engaged and retained in care, which means that once you see that doctor, you continue to see that doctor and you show up to your appointments. And then your fourth hexagon is that you are prescribed antiretroviral therapy. You're prescribed drugs that will help you achieve viral suppression. Which is your last hexagon. Achieving viral suppression essentially means that you are below the threshold that you are at risk for transmitting HIV to other people. In this context, that is 1,000 copies of virus per milliliter. So a little bit of context, HIV in Vietnam, it's actually really low, the prevalence, it's at 0.4%, but they do have a lot of new cases, over 10,000 each year. And over 7,000 people die from AIDS each year because, unfortunately, less than 50% of the population is on treatment. The populations who are largely impacted by HIV are persons who inject drugs, female sex workers, and men who have sex with men. This is pretty common in the United States as well, with these sorts of populations who are at risk for HIV transmission. So for my project, I partnered with this program called HIVietnam, the Partnership for Health Advancement in Vietnam. It was established to improve the Vietnamese healthcare system's management and care of HIV. And so it's a partnership between Harvard Med School, Beth Israel, Brigham and Women's Hospital, and the Vietnamese Ministry of Health and their affiliated hospitals. They have 2 main locations. The first one is in Hanoi, which is where the Yellow Star is, where I was based this past summer. And then the second one is in Saigon, also known as Ho Chi Minh City, which is in the southern portion of Vietnam. And so they implemented this program called Enhanced Adherence Counseling to help to support patients who fail to achieve viral suppression. So then my question was, among patients who fail to achieve viral suppression, does enhanced adherence counseling help patients achieve resuppression? And are there secondary factors that influence resuppression? And so for our study, our subject criteria was that you had to be 18 or older. Your viral load had to be 1,000 copies per milliliter or more. That's essentially what we consider as no longer resuppressed. And that test had to be done between January of 2017 and January of 2018. And you had to be on first-line therapy. For HIV drug medication, there are 2 lines of therapy. The first line of therapy is ideally the one that you want to be on because there are less drugs, there are less side effects. It's the newer class of drugs that are a lot more effective. The second line therapy is usually what you get switched to if you're not responding to your drugs and the virus has developed a mutation that becomes resistant to the first line of drugs. The second line of drugs are a little bit more harmful in terms of the side effects that you can experience, as well as just having more pills to take, which can be a lot more complicated for patients. And so to collect all this data, we used a data collection tool. So this is the first half of our form, and I want to draw your attention to the 3 that are highlighted in red. So the date that you have confirmed HIV, so how long you've been HIV positive, because that can tell you a lot about their capacity and their understanding of their disease. And the day you started your drug regimen, there's sometimes a discrepancy between the date you're confirmed with HIV and the date you start medications, simply because of resource and accessibility, which is common in like Vietnam and a lot of other countries that aren't in the United States. And then your regimen, so like the actual like drug that you're on, and that tells you whether or not you're on first line or second line therapy. And that also helps us determine whether or not you have changed to second line therapy within this study period. And so the second half of our data form is tells you all of this stuff. So I want to draw your attention to the first 3 boxes. The first one is your viral load after your initial viral load. So ideally, you're supposed to have your first viral load, and then you're supposed to go through your counseling sessions, and then you have another viral load. And that tells you whether or not your viral load has increased, decreased, stayed the same, and that sort of thing. And then the second is whether or not a genotype was done. And so a genotype essentially tells you whether or not there are mutations detected in the virus. And so a lot of patients will claim that they are taking their medications on time, and like some of them really do. And it could be that the reason that their drugs aren't working is because that their virus has a mutation, and that mutation causes the virus to be resistant to those drugs. And in that case, that's when you usually switch to a different class of drugs. And so that's really important, because it could be that like it's not actually because the patient doesn't understand how to take their drugs, it's actually because of the biological factors in their virus. And so whether or not the patient was changed to second line is one of our important questions, because if you're changed to second line, your body hasn't had time, the virus in your body hasn't had time to like react and sort of develop defense mechanisms against those drugs. So that could be a reason why your viral load has actually decreased, and it's not actually due to any other specific reason. And so, based upon all of this data that we've collected, we created a model about what would happen based upon each factor. So your blue line is the simplest one. It's the enhanced adherence counseling session on your x-axis and your viral load on your y-axis. The line that is horizontal at 5, that is what is considered virally suppressed. So that is below 1,000. And so it shows that as you do more sessions, theoretically, the model predicts that your viral load will decrease. And if you look at around 3, which is in this middle section right here, that's actually where the viral resuppression is achieved. And so the thing we wanted to see, though, was if you add on other layers, other factors that can complicate this sort of relationship, what happens? So if you are switched to second line, which is the green line, it actually takes a lot longer for you to achieve viral resuppression. And theoretically, that makes sense, right? Because if you're changed to second line, it usually means that you're not taking your drugs correctly. So there's a lot more virus. It takes a lot more time to achieve resuppression. And so if you do a genotype, it shows that it takes a little bit longer as well. And then if you add all of those layers together, that's the purple line, it takes the longest amount of time. And it actually takes a little bit more than 4 sessions to achieve resuppression. And so this model shows for low, which is 2 years, it's the amount of time. 2 years is like the amount of time you've been diagnosed, so that's like the relationship. So if we wanted to compare it between like people who have been diagnosed for HIV for longer versus shorter amounts of time. So for this, you can see that that like for people who've been diagnosed for HIV for a shorter amount of time, start at a higher amount in terms of the viral load, but it takes them longer to achieve viral resuppression compared to the people who have been diagnosed for HIV a lot longer and have theoretically understand their disease more. And also sometimes, though, it's interesting because while it takes them less time to achieve resuppression, it sometimes makes them a little less likely to actually take their medication because they're really tired of taking their drugs. So like pill fatigue makes them less likely to adhere to their medication. So it's a little bit interesting, that kind of relationship that's seen in these 2 models. So what does this all mean? It means that EAC is associated with lower viral loads, but other factors like subject motivation weren't accounted for. That means we can't be like EAC leads to decreased viral load. It means we can say that it theoretically factors into a decreased viral load, and that we should be doing these sessions because they could have an impact, but we can't say that this will impact all subjects and help all subjects achieve viral suppression because of things like motivation and their own understanding of their disease and how it works. And so it was shown also that like if you're on second line, your viral load is theoretically decreased, which makes sense given the fact that if you are suddenly changed to a new class of drugs, the virus in your body has yet to sort of develop defense mechanisms. And so it's in the context of what this all means for public health and how we should be implementing these things, it shows that like while it doesn't work for everyone, we should still be doing it because it does have some theoretical potential impact on helping these patients achieve viral resuppression. Thank you.
How available are these counseling sessions to your average patient in Vietnam?
So it really depends on terms of the clinic that you go to. So theoretically, theoretically you're supposed to attend them, but like not every patient attends them. So it really just depends on like the person and how far away they live to the clinic and how willing they are to go, if that makes sense. Yeah.
How was that model you created constructed? Did you actually administer these surveys and collect the data to construct this?
Yeah, so I went to Vietnam this past summer and we collected data using that data collection tool that I mentioned earlier. And then we entered in the data and into a spreadsheet, and we essentially did this type of analysis called multi-level modeling analysis, and it allows every patient to start at a different viral load, at a different capacity, and it then even though like everyone starts at different places, it essentially constructs a relationship for each patient and then calculates a like overall predictive model. Yeah.
What happens in an enhanced adherence counseling session?
It's supposed to be really patient unique because each patient is different in terms of like how long they've been diagnosed, how far away they live, and what their risk factors are. Because like if you are an intravenous drug, a person who injects drugs, your risk factors for HIV are a lot different than a person who doesn't inject drugs, right? So it really depends. So like if a patient like just doesn't understand how to take their medication, that could be what goes on in a counseling session. You're helping them understand like why you need to take these drugs and why you need to take them at this specific time every single day and like how to take those drugs. Because some people also might just not understand how to take drugs. Yeah. Any other questions? Yeah.
Your survey, was that given to the doctors?
No, so what we did was we went to the clinics and we took all the patient charts and then we abstracted data from those clinical charts. Yeah, so some of the data was missing, unfortunately, because like certain things like risk factors aren't necessarily recorded because of stigma that is associated with being a female sex worker or being a person who injects drugs. Masha?
Are there factors that make people more or less likely to take drugs well?
What, like their medication well?
Yeah, to take their medication on time.
We didn't really analyze that portion of the data in terms of like whether or not this makes them more likely to take their medication, because we didn't really have any sort of qualitative data that indicates whether or not like their like motivation to take their drugs.
Is the provision of EAC across Vietnam common, or does that program you work with like implement this at the clinics? Or?
Yes, so they're starting to implement it throughout Vietnam, but it's a slow process because you have to train all the doctors and you have to make sure that they understand how to do it. And also there's this issue of how like not every doctor wants to do it because it takes a lot of time and it's very busy and it's a lot of work, and also patients won't show up, so it disincentivizes that sort of like implementation process. But in the clinics that have been trained mostly in like Hanoi and Saigon, it's supposed to be happening. In areas outside of that, we actually analyzed a data set from another province, and it showed that it wasn't really working, but it makes sense because they haven't really been properly trained. So like the fact that there was some sort of documentation of it happening was surprising in of itself. Yeah. Any other questions? Okay. Thank you guys so much.